She looks completely fine. She works. She takes care of her family. She smiles when you walk into the room. Ask her how she's doing and she'll tell you the same 3 words every time. I'm fine. But watch her for a week and you'll notice things. Water bottles that never leave her side. Eye drops in her bag, her car, her nightstand. A familiar word that vanishes mid-sentence, laughed off before you even register it happened. Here's what I'm not going to do in this video. I'm not going to hand you a checklist of dry eye symptoms and call it a day, because if you've spent any time researching Sjogren's, you already know that list. What I want to show you is something different. 3 things most videos on this topic never get to. One of the strongest clues has almost nothing to do with dry eyes at all. Another one sends women to the wrong specialist for years, because it wears a completely different disguise depending on who's looking at it. And the clue I most want parents, grandparents, and teachers to hear is one that shows up differently, sometimes completely differently, in girls than it does in grown women. In a US survey of more than 6,000 adults living with Sjogren's, nearly 1 in 3 said it took 5 years or longer to get diagnosed. Not because nobody was paying attention. Because the clues were scattered across 5 different doctors, and nobody was holding all 5 pieces at the same time. I'm going to give you 2 people to follow through this video, like 2 open case files. A working mother named Lisa, and a 15-year-old girl named Maya. Neither one is a real patient. They're composites, built from patterns reported again and again by women and girls living with this disease. By the end, I want you to be able to look at their files and see what it took their doctors years to see. Stay through the blood work section. That's the part where this stops being a symptom list and starts being a mystery with an actual answer. If you want the full Sjogren's symptom map guide with visuals, symptom breakdowns, and additional resources, type symptom map in the comments, and I'll send you the link to access it. Lisa is 47. She has a full-time job, 2 kids, and a calendar that never stops moving. If you met her at a school pickup line, sick would not be the word that came to mind. Lisa doesn't think there's anything wrong with her either. Here's the script running in her head, on repeat, so often she doesn't notice she's reciting it. I'm just getting older. I work too much. It's probably menopause. Everyone forgets words. I need more sleep, that's all. Every one of those sentences is reasonable on its own. That's exactly why they work so well as cover. A single reasonable explanation is easy to believe. 5 reasonable explanations, stacked on top of each other, covering 5 different symptoms, is a much harder thing to notice, because each one gets accepted individually, and nobody ever adds them up. Here's the framework for the rest of this video. What she feels, what she changes, and what everyone else sees are 3 different things. Usually only the third one is visible to anyone but her. Lisa never says, "My mouth is dry." She just stopped eating without a drink nearby, years ago. No complaint. No conversation with a doctor. Just a small permanent adjustment made so long ago she doesn't register it as a symptom anymore. She registers it as a habit, the same way she'd register always carrying a phone charger. The clue isn't always the symptom. It's the accommodation she stopped noticing she was making. That single idea is going to reappear in almost every section of this video, so hold on to it. And the first mask has nothing to do with looking sick. It's the one that makes her look like she has it all together. Mask 1, she functions beautifully, then crashes. Lisa's morning, kids ready, commute, a full workday, groceries on the way home, dinner on the table, a smile through all of it. What nobody sees, for extra minutes sitting in the driveway before she can make herself go inside. Lying down the second she walks in the door, still in her work clothes. Evening plans cancelled, again, with a text that says something came up. Entire weekends lost to sleep that never actually feels like rest. Standing in the bathroom doing quiet math, enough energy to shower, or enough to cook dinner, but not both, so one of them has to lose. In a 2025 US survey, fatigue was named the single most negatively impactful symptom by 27% of respondents. Higher than joint pain. Higher than dryness. Higher than anything else on the list. Quick test. 2 women described their week to a friend over coffee. Woman A says her eyes have been bothering her lately, dry, irritated, annoying enough that she mentions it out loud. Woman B says nothing about her eyes at all. She just happens to own 5 bottles of eye drops scattered across her house and car, drinks water with every single bite of food without thinking about it, and has slept through the last 3 Saturdays in a row without meaning to. Which one looks sicker? Most people would say woman A, because she's the one who complained. But woman B is very likely carrying the heavier load. She's just gotten better at hiding it, so much better that even she might not describe herself as unwell. Coping ability and symptom burden are not the same thing, and that gap is exactly what makes high-masking patients so easy to miss, both to the people around them and sometimes to themselves. One more thing before we move on, because I don't want anyone diagnosing themselves off one paragraph. Ordinary tiredness has 100 causes. Fatigue by itself proves nothing. The question was never, is she tired? The question is what else is showing up alongside it. Mask 2, she doesn't say dry, and why that actually makes sense. Don't ask, is your mouth dry? A high-masking woman will often say no, not because it's untrue, but because she solved the problem herself years ago and stopped thinking of it as a problem worth reporting at all. Look at behavior instead. Water with every meal, no exceptions. Avoiding crackers or dry bread unless there's something to wash it down. Gum or lozenges always within reach, in her bag, her desk drawer, her car's cup holder. Sipping mid-sentence while talking, almost like punctuation. Waking at night needing a drink before she can fall back asleep. An unexplained rise in cavities her dentist has commented on more than once. Food that's noticeably harder to swallow when it's dry. Taste that's shifted, subtly, in ways she can't quite put into words. Picture the dentist appointment. He points at the new cavities on the X-ray and asks if she's been flossing. She says yes, because she has. He shrugs it off as one of those things, writes a note, and moves on to the next patient. Neither of them has any reason to connect it to anything else, because in that room, it's the only symptom that exists. Now the eyes. Drops in the handbag, the car, the nightstand, sometimes all three at once. Avoiding fans and air vents at work. Screens that get uncomfortable faster than they used to, so she looks away more often without really noticing she's doing it. A gritty, sandy feeling that doesn't fully go away no matter how much she blinks. Burning. Blurry vision that comes and goes throughout the day. Contact lenses that used to be effortless and now genuinely aren't. Here's why this happens in the body, in one sentence, because it matters for everything that comes later. Sjogren's is an autoimmune condition where the immune system targets the glands that produce moisture, tear glands, salivary glands, and others like them scattered throughout the body. That's why eyes and mouth show up together so often. They are not two separate problems that happen to coincide. They are the same underlying process, showing up in two different places. Hold on to that sentence. It's going to explain something stranger later on, a symptom that appears to have nothing to do with moisture at all, and that most people never think to connect. And if some of you are already thinking, but my antibody test came back negative, so this can't be it, hold that thought too. Negative blood work does not automatically close the case. I'll show you exactly why later in this video, and what doctors look at instead when the antibodies don't cooperate. For now, just know the door isn't closed. 2 entries in her file so far. 2 visible clues, and neither one has ever come up with a doctor, because she solved both of them herself before anyone thought to ask a follow-up question. Here's a tool to carry through the rest of this video. Every clue we cover fits into one of 4 buckets. Moisture, energy and brain, pain and nerves, glands and systemic. 1 clue in 1 bucket, on its own, can mean 100 different things. Menopause, stress, aging, a rough month, a bad night's sleep. But when clues start stacking across several buckets, in the same person, over time, that's when a pattern becomes worth bringing to a clinician. Not a diagnosis. A pattern worth a real conversation. Lisa currently has 2 entries, both in the moisture bucket. Let's keep filling the file, because what happens next is where most people watching this will start recognizing someone they know. Mask 3, brain fog disguised as being organized. Reminders for everything. Sticky notes on the fridge, the bathroom mirror, the dashboard. Lists in 3 different apps that all somehow have different information on them. Rehearsing what she's going to say before a phone call, like she's preparing for a presentation instead of a 10-minute conversation. Rereading the same paragraph twice before it actually lands. Familiar words disappearing mid-sentence. Words she's used 1,000 times, gone, replaced by the thing and a hand gesture. Walking into a room and forgetting why, standing there for a second before giving up and walking back out. Losing the thread of a conversation with more than one topic when she's tired, nodding along until she can catch back up. Picture a co-worker watching Lisa's desk, color-coded folders, a whiteboard with deadlines, 3 sticky notes on her monitor, and saying, "I don't know how you keep track of everything, you're so organized." Inside Lisa's head, that compliment lands differently. "If I don't write this down right now, I will lose it completely." Same mechanism as before, moisture-producing glands aren't the only thing affected. Inflammation connected to Sjogren's can influence other systems too, and brain fog is one of the most commonly reported effects, often alongside sleep that never fully restores her no matter how many hours she gets. Caveat, and it's an important one, brain fog is nonspecific. Poor sleep causes it. Certain medications cause it. Depression causes it. Menopause causes it. On its own, it means almost nothing at all. File note for Lisa: cognitive symptoms, compensated for with external systems. Bucket: energy or brain, second entry. 3 entries now. Still nothing she's ever said out loud to a doctor, because every single one of these has already been solved quietly, on her own, without anyone else's help. This is the section I most want women between 45 and 65 to hear, because it's the explanation that fits best, and that's exactly what makes it worth a second look. A woman in her late 40s or 50s can develop fatigue, poor sleep, brain fog, aches, vaginal dryness, dry skin, and mood changes as part of a completely normal menopause transition. All of that is real. Nobody in this video is disputing that, and nobody should walk away thinking menopause is something to be afraid of. So it's just menopause isn't an unreasonable thought. It's the most logical explanation available to her, given everything she's ever been told to expect at this stage of life. Here's how you'd actually tell the difference, not by throwing out the menopause explanation, but by testing it against the whole file, symptom by symptom. Menopause doesn't typically explain persistently gritty eyes that never improve no matter how much sleep she gets. It doesn't explain dental problems that keep getting worse despite good hygiene and regular cleanings. It doesn't explain gland swelling along the jaw that keeps recurring for no clear reason. It doesn't explain fingertips that turn white or numb in the cold, only to flush red as they warm back up. It doesn't explain tingling or burning sensations that have nothing to do with hot flashes and don't follow any obvious pattern. Menopause can explain a tired, foggy, achy woman in her early 50s. It has a much harder time explaining a tired, foggy, achy woman whose eyes and jaw and fingertips are also telling a story of their own. The question was never whether menopause could explain one symptom in isolation. It's whether it explains the entire file, front to back, without leaving pieces unaccounted for. No fear here, menopause is not, on its own, a red flag for autoimmune disease, and most women going through it have nothing further to investigate. This is about noticing the moment when one explanation is being asked to cover more ground than it can reasonably carry. Mask 4, pain hidden inside small decisions. Lisa doesn't announce joint pain. It shows up as small decisions nobody ever questions, because they look like ordinary preferences instead of symptoms. Someone else opens the jars now, and it's been that way long enough that nobody remembers when it started. The elevator quietly replaced the stairs. Certain shoes have vanished from her closet, replaced by ones that don't require as much bending or gripping to put on. Her morning routine takes longer than it used to, though she'd never describe it that way. Gripping a pen or a steering wheel for a long drive is harder than it used to be. She avoids plans that involve a lot of walking, and finds an easy excuse each time, without ever naming the real reason. Watch for one more thing: fingertips that turn unusually pale or white in the cold, followed by numbness, pain, or a rush of red as they warm back up. That's called a Raynaud type change, and it shows up often enough alongside Sjogren's that it's worth paying attention to, even though plenty of people experience it with no connection to autoimmune disease at all. So she buys gloves, a nicer pair than she used to bother with. Everybody sees the gloves. Nobody sees why she actually needs them, and she's never once been asked. File note for Lisa: joint stiffness, grip changes, cold sensitivity in the fingers. Bucket: pain, nerves. 4 entries now. 4 separate doctors could have caught 1 entry each, in 4 separate rooms, on 4 separate days. None of them ever saw the full file, because the file didn't exist anywhere except inside Lisa's own daily habits. Now set Lisa aside for a moment, because I need you to picture someone completely different. Not your co-worker. Your daughter. Your granddaughter. Your niece. The kid in your classroom who never causes any trouble at all. Maya is 15. She goes to school, laughs with her friends at lunch, gets her homework done most nights, plays on a rec league team on weekends. If you saw her in a hallway, sick is the last word that would ever come to mind. But every few weeks, there's swelling around her cheek and jaw. It comes. It stays for a few days. It goes. Nobody's quite sure why, and it's easy enough to write off as a swollen lymph node from whatever bug is going around school that month, or a reaction to something she ate. Her mom mentions it to the pediatrician once, almost as an afterthought at the end of an unrelated visit, and it gets logged and forgotten. Here's the twist that catches most people off guard, including a lot of doctors who are only trained to look for the adult version of this disease. In younger patients, the classic dry eye, dry mouth symptoms that everyone associates with Sjogren's can be far less prominent, or almost absent entirely. Recurrent salivary or parotid gland swelling is often a much bigger clue in kids and teens than dryness is, which means a doctor looking for the adult textbook picture can walk right past a child who has the disease. Other things worth watching in a girl like Maya, and having properly evaluated rather than dismissed: recurring gland swelling that keeps coming back over months, persistent fatigue that doesn't match her activity level or her age, joint or muscle complaints that seem to move around, neurological symptoms, and other findings that don't have an obvious explanation once you start listing them out. One line, and I want it to stick, because it's the single most important sentence in this entire section: a tired teenager does not equal Sjogren's. A swollen gland does not equal Sjogren's. Almost every teenager gets tired, and almost every swollen gland has an ordinary explanation. What matters is a pattern that keeps recurring, doesn't fully resolve, and doesn't have a clear cause after a reasonable amount of time. File note for Maya: recurrent parotid swelling, first entry. Bucket, glands, systemic. A completely different starting point than Lisa's file. Same disease, wearing a different disguise depending on the age of the person carrying it. Mask 5, the strange symptom nobody connects. Back to Lisa's file, and this is where the mechanism we set up earlier finally pays off. Tingling, burning, numbness, electric, shock-like sensations that come out of nowhere. Balance problems with no clear trigger. Nerve pain that doesn't match any injury she can remember. One woman assumes it's a pinched nerve from sitting at a desk all day. Another assumes poor circulation. Another starts quietly wondering about diabetes, and maybe even gets tested for it, only for the results to come back normal. Remember what I told you back in the dryness section: Sjogren's targets moisture-producing glands, but the underlying immune activity isn't confined to them. It can affect nerve fibers too, which is exactly why neurological symptoms show up in this disease far more often than most people expect, and why they get misdiagnosed as something else entirely, sometimes for years. This is where a neurologist gets involved, along with nerve conduction testing, small fiber neuropathy evaluation, and in select cases, an MRI to rule out other explanations. Here's the detail almost nobody hears, and it's a genuinely important one. A standard nerve conduction study can come back completely normal even when small fiber neuropathy is actually present, because that particular test isn't built to catch that particular kind of nerve damage. The type of neurological problem matters enormously. A clean test doesn't automatically mean nothing is wrong, and a normal result shouldn't be the end of the investigation if the symptoms keep showing up. For Maya, this bucket can look different too. Neurological or systemic symptoms in a teenager often require a separate pediatric evaluation entirely, because test norms, reference ranges, and diagnostic criteria built around adults don't always translate cleanly onto a growing body. File note for Lisa: neurological symptoms, unexplained, previously attributed to a pinched nerve. Bucket, pained nerves, second entry. 5 buckets are filling now, spread across years and specialists who never spoke to each other. Mask 6, the symptoms women don't talk about. This part is for the adult women watching, kept short and treated with the respect it deserves. Vaginal dryness, irritation, pain during intercourse, changes in sexual function that developed gradually enough to feel like something to just live with. Certain urinary or bladder complaints that deserve their own proper evaluation rather than being lumped in with everything else. These carry more silence than almost anything else in this video. Not because they are rare, because they are embarrassing to bring up, even to a doctor, even when that doctor has heard it all before. If she's too uncomfortable to mention it, her rheumatologist may never hear it. And a symptom nobody hears about is a symptom nobody can ever connect to the rest of the file, no matter how thorough that rheumatologist is. File note for Lisa: moisture symptoms, second entry, never disclosed at any appointment, including the ones specifically meant to catch it. Everything so far has been about noticing quiet accommodations, small, private workarounds that let life keep functioning. This section is different. There's one point where pushing through stops being admirable and starts being genuinely risky, and it's worth knowing exactly where that line sits. Sjogren's is systemic, which means it isn't limited to glands, joints, and nerves. Persistent or unusual gland swelling that doesn't resolve. Swollen lymph nodes that don't go away after a couple of weeks. Unexplained shortness of breath or a chronic cough that has no obvious respiratory cause. Unusual skin findings, like small clusters of purple or reddish spots known as purpura. Significant neurological changes that progress rather than staying stable. Unexplained systemic symptoms in general, the kind that don't fit neatly into any one bucket. In some patients, these are connected to lung involvement, kidney involvement, blood vessel inflammation, and in rare cases, lymphoma. I'm not telling you this to frighten anyone watching, and the overwhelming majority of people with Sjogren's never experience the more serious end of this list. I'm telling you this because these aren't symptoms to quietly build another accommodation around, the way Lisa did with the water bottle and the eye drops and the gloves. These are symptoms that belong in a doctor's office, not folded into a daily routine and forgotten about. Here's the part one told you at the very beginning to stay for. But my blood work was normal. This might be the single most common sentence in Sjogren's support groups and forums, and it's a far more complicated sentence than most people realize, on both sides of the conversation. There is no one universal blood test that answers every question here, no matter how thorough the lab panel looks on paper. Doctors typically look at a combination of several things together: anti-SSA-RO antibodies, anti-SSB ALA antibodies interpreted in context rather than alone, ANA and rheumatoid factor where relevant to the broader picture, objective eye testing that measures tear production rather than just asking about symptoms, salivary flow evaluation, salivary gland imaging, and in select cases, a minor salivary gland or lip biopsy that looks directly at the tissue involved. Here's the twist, and it's one that deserves far more attention than it usually gets. There's a recognized category called seronegative Sjogren's. Antibodies come back negative on standard testing, but the disease is still present, confirmed instead through the other testing described above. It's real, it's documented in the medical literature, and it's common enough that a negative antibody result has sent plenty of women home with the message that nothing's wrong, when something clearly was, simply because the wrong tool was used to close the case. Equally true in the other direction, and just as important, symptoms alone don't prove the diagnosis either, no matter how many boxes on this list get checked. Both of those sentences are true at exactly the same time, which is precisely why this requires an actual clinical workup performed by someone with the right training, not a symptom checklist from a video, and not a single lab value taken in isolation. For Lisa, this is the moment her file stops being 6 disconnected notes scattered across 5 years and starts being evidence, once someone finally lines it all up in one place. For Maya, it's the reminder that a negative test result in a 15-year-old shouldn't necessarily end the conversation either, especially given how differently this disease can present at her age. Before we open Lisa's file completely, try this yourself. Picture 5 appointments, each one on its own separate day, months, or years apart. At the dentist, you mention nothing, because there's nothing to mention. You already drink water with meals, so your mouth never feels dry enough to bring up. At the eye doctor, you get a prescription for artificial tears and move on with your day. At your annual physical, you mention you've been tired, and you both agree work has been a lot lately. At the gynecologist, you mention some changes, and you both agree it sounds like a normal part of getting older. At urgent care, for the tingling in your feet, you get told it's probably nothing and to follow up if it gets worse. Now put all 5 visits on one page, side by side, in front of you. Water dependency. Eye drops. Exhaustion that outpaces your schedule. Symptoms explained by aging. Nerve tingling with no clear cause. If you were the 6th doctor, the one finally looking at all 5 notes at once instead of just one, would you see 5 unrelated complaints, or would you start asking a different question? That's the exact gap Lisa has been living inside for 5 years. Not because any single doctor did something wrong. Because no single doctor ever saw the whole page. Let's open Lisa's full file, side by side, the way nobody in her life ever actually got to see it. 6 entries. 5 buckets. Collected over roughly 5 years, 1 appointment at a time, never once compared against each other until now. Her dentist saw the cavities and the dry mouth and treated it as a dental issue, prescribed a stronger toothpaste, and scheduled a follow-up in 6 months. Her eye doctor saw the dryness and the fluctuating vision and treated it as ordinary aging eyes, recommended over-the-counter drops, and moved on to the next patient. Her primary care doctor heard about the exhaustion during an annual physical and attributed it to being overworked and underslept, which, to be fair, wasn't entirely wrong, just not the whole story. Her gynecologist heard about the menopause-adjacent symptoms during a routine visit and treated them as a normal transition, which again, wasn't wrong, just incomplete. A neurologist eventually heard about the tingling, ran a nerve conduction study that came back normal, and temporarily closed that lead without pursuing it further. It took a 5th visit, finally, a rheumatologist, referred almost by accident after a routine blood work flag, to lay all 5 files next to each other on one screen and see one connected pattern instead of 5 separate, unrelated problems. In a 2025 U.S. Sjogren's Foundation survey, respondents reported seeing an average of 5 different healthcare providers per year. Lisa's file isn't an exaggeration built for a video. It's close to the average experience reported by real patients. 5 doctors can mean 5 separate pieces of the same woman, and nobody along the way was failing her on purpose. Each one solved the piece directly in front of them, correctly, based on what they could see in their own exam room. The system was never built to automatically connect those 5 pieces into one picture. Somebody has to do that on purpose, and until she finds the right specialist, or brings the full file in herself, that somebody is usually her. After nerve symptoms, systemic warnings, 5 years, and 5 doctors, this can start to feel heavy by design. So here's the part that isn't, and I think it matters more than anything else in this video. The point of recognizing this pattern was never to hand yourself a new disease to worry about, or to send you searching for symptoms you don't actually have. It's to stop treating 5 unexplained problems like 5 personal failures, 5 things you were supposedly bad at managing on your own, when really they were one thing nobody had connected yet, because nobody had ever seen the whole file at once. That reframe alone is worth something, whether or not a formal diagnosis ever follows. You were never failing to keep it together. You were successfully managing something nobody had named for you yet. Think about what that actually means for someone like Lisa. She never once thought of herself as resilient, she thought of herself as someone who was slightly disorganized about her health, someone who kept meaning to deal with it and never quite got around to any of it. But reread her file. 6 symptoms, 5 buckets, 5 years, and she still got the kids to school on time every single morning. That's not disorganization. That's an enormous amount of quiet capability, spent holding together a body that was working against her the entire time, without anyone, including her, realizing that's what was actually happening. The same is true for a girl like Maya. Nobody would ever describe a 15-year-old managing recurring swelling and unexplained fatigue, while still keeping up with school and friendships as anything other than fine. But fine and not struggling were never actually the same thing. They just look identical from the outside, which is the entire reason this video exists. Before your next appointment, build a 1-page timeline instead of a symptom list, because a timeline is what actually helps a clinician see the pattern instead of 5 isolated complaints. Write down when each problem started, even if it's just an approximate season or year. How often it happens now. What tends to show up together on the bad days versus the good ones. Eye problems. Dental changes. Any gland swelling, including how long it lasts. Pain patterns, including which joints and when. Nerve symptoms, described as specifically as you can manage. Fatigue that doesn't match the effort of your actual day. What you quietly do to compensate for all of it. The water, the drops, the gloves, the reminders. Previous test results, even ones that came back normal. Any autoimmune history anywhere in your family. The best question to ask yourself while you write it, the one this entire video has been building toward. What have I changed about my life because of my body, that I no longer even think about? That's the high-masking question. That's usually where the real answers have been hiding the entire time, disguised as ordinary habits. Lisa looked fine because, over years, she quietly built a system of small accommodations around every single symptom on this list, one habit at a time, until the symptoms themselves became invisible even to her. Maya looked fine because everyone around her, including the adults responsible for her care, was expecting Sjogren's to look like the adult textbook version, not a laughing 15-year-old with an occasional swollen cheek and nothing else that seemed unusual. So how do you actually spot Sjogren's in a woman or girl who looks fine? You stop judging how sick she is by how sick she looks. You notice the water she always needs. The drops she never leaves without. The recovery time after an ordinary day that other people don't seem to need. The reminders she can't function without. The swelling that keeps returning. The pain she stopped mentioning years ago. The 5 different doctors, each holding one piece of a puzzle nobody has ever assembled in the same room. None of it is diagnostic on its own. Not one single clue, by itself, proves anything at all. But when the pattern keeps repeating, across buckets, across years, across specialists who never once compared notes, that's when looking fine shouldn't be the thing that ends the conversation. Looking fine can tell you how well she's learned to cope. It doesn't always tell you how well she actually feels. Somewhere watching this right now is a version of Lisa who just recognized her own water bottle, her own gloves, her own 3 sticky notes on the bathroom mirror. And somewhere watching this is a parent who just remembered a swollen cheek from 2 years ago that never got a second thought. Neither of those things is a diagnosis. Neither one means anything by itself. But both of them are worth writing down, worth bringing to an appointment, worth finally putting on one page instead of leaving scattered across 5 separate conversations that never got to talk to each other. That's really all this video was ever asking you to do. Not to panic. Not to self-diagnose from a symptom list on the internet. Just to stop treating "she looks fine" as the end of the question, and start treating it as the beginning of one. If you've ever heard the words "but you look fine," type "look fine" below. You won't be the only one.